You sit on the toilet. You know you need to go. You can feel it right there almost out. So you push. Nothing. You push harder. Still nothing. Then you stand up, frustrated. And 10 minutes later, that same pressure is back again, like your body never finished the job. Now, here's the part that should get your attention. If you're over 60, and this keeps happening, the problem may not be constipation at all. In fact, your body might be making plenty of stool. It might already be sitting exactly where it's supposed to leave your body, and yet it still won't come out. Why? Because one tiny group of muscles, hidden deep in your pelvis, may be working against you every single time you try to have a bowel movement. Most people have never heard of these muscles. Most doctors never explain them, and because of that, millions of older adults spend years drinking more water, eating more fiber, taking stool softeners, and wondering why nothing really fixes the problem. But what if the blockage isn't higher up in your intestines? What if it's happening in the final few inches right at the exit? Today, I'm going to show you exactly what happens during a normal bowel movement, why stool can get stuck right at the very end, even when it's ready to come out, the surprising signs that point to this hidden problem, and the specific questions you should ask your doctor if this sounds familiar. Because once you understand what's really happening, you'll never look at constipation the same way again, the feeling that something is stuck. Let's start with the exact sensation, because this matters. You feel the urge to go. The stool seems to be right there, almost at the opening, but it won't come out. You push, wait, try again, and maybe only a small amount passes. Then, minutes later, the urge returns, leaving you feeling like you never completely emptied. Some people describe it as, the stool is there, but the door won't open. Others have to lean forward, change positions, or strain for a long time just to finish. If this sounds familiar, don't automatically assume it's simply because you're over 60. A bowel movement isn't controlled by fiber and water alone. The colon has to move stool into the rectum, your nervous system has to recognize the urge, and the pelvic floor muscles need to relax at precisely the right moment, while other muscles create enough pressure to move the stool out. If that coordination doesn't happen properly, stool can reach the rectum but still feel stuck. This is sometimes called defecatory or pelvic floor dysfunction. That doesn't mean you have this condition. Hard stool, medications, chronic constipation, hemorrhoids, and other problems can create similar symptoms. The important point is this. Regular bowel movements don't always mean you're emptying properly. So if you repeatedly strain, pass only small amounts, or constantly feel something is left behind, don't simply accept it as normal aging. It's worth describing these specific symptoms to your doctor, so they can determine what's actually causing the problem. And that's important, because if the difficulty is happening at the exit, simply adding more fiber isn't necessarily going to solve the problem, because sometimes the issue isn't making the stool, it's getting the final few inches to work together properly. Why this can change after 60. Your bowel doesn't suddenly stop working because you turned 60. What changes is that several small things can start adding up at the same time. And you may not notice them until one day you're sitting on the toilet, pushing, waiting, and thinking, why has something that used to be automatic become so difficult? You may move less than you used to. Your diet may become smaller or less varied. You may drink less because your sense of thirst isn't as strong. Medications can accumulate over the years, and many commonly prescribed medicines can slow the bowel as a side effect. But there's another change that's easy to overlook. The nerves and muscles that sense fullness and coordinate the final stage of a bowel movement can also change with age. And if you've spent years straining, holding your breath, or repeatedly forcing stool out, you can get caught in a frustrating cycle. The harder you push, the more difficult the process can become. That's why this can feel frightening. You start wondering, is this just aging? Is something wrong with my body? Will I have to live like this from now on? Not necessarily. Aging doesn't automatically mean you have to accept difficult bowel movements as your new normal. There can be several contributing factors, and many of them can be addressed once you identify what's actually happening. The key is not to search for one magical fix. It's to find out which part of the system isn't working properly for you. Because once you know that, what feels like a permanent problem can become something you can actually do something about. The part nobody explains. The exit has muscles. Here's the part almost nobody explains. Your bowel movement isn't just about pushing. Your exit has muscles, and they have to work together. As stool travels through your colon, water is gradually absorbed. Eventually, stool reaches the rectum. When the rectum fills and stretches, nerves send your brain the signal. It's time to go. Now the important part happens. Your abdominal muscles create pressure from behind, helping move the stool forward. But at that exact moment, your pelvic floor and anal sphincter need to relax and open. The passage also changes its angle slightly to help the stool move through. Think of it like a door. You can push as hard as you want from behind, but if the door is tightening instead of opening, more pressure won't solve the problem. And this is why some people get trapped in a frustrating cycle. They feel stool sitting right there. They push harder, nothing happens, so they push even harder. But the problem may not be a lack of force. It may be a lack of coordination. For a bowel movement to happen smoothly, pushing and relaxing have to occur together, in the right sequence. When that coordination doesn't happen properly, you can experience exactly what we described earlier. The stool feels like it's at the exit, but somehow the exit won't open. And once you understand this simple mechanism, you'll also understand why just eat more fiber doesn't always solve this particular problem. When pushing actually makes things worse, this is one of those points that surprises people. Because it goes against the instinct most of us have. If stool isn't coming out, the natural response is to push harder. But if the muscles at the outlet aren't relaxing properly, if they're tightening instead of opening, then pushing harder doesn't solve the underlying issue. It can just increase pressure against a door that isn't opening. Over time, repeated hard straining can also contribute to other problems, including hemorrhoids and increased pelvic floor tension, which can make the coordination problem even worse. This is part of why the standard advice, more fiber, more water, more effort, sometimes doesn't fully work for people with this specific pattern. Before we go further into causes, it's worth mentioning something simple that can genuinely change the mechanics for some people. How you're sitting. A more supported position tends to help the anorectal angle straighten more effectively. That generally means having your feet supported on the floor or on a small stool so your knees are slightly higher than your hips, leaning your torso forward rather than sitting bolt upright. Letting your abdomen relax rather than holding it tense, and breathing steadily instead of holding your breath while straining. This isn't a universal fix, and it won't resolve every case on its own. But for some people, it removes one small mechanical obstacle that was working against them the whole time. Why more fiber isn't always the answer. This next part needs a bit of nuance, because fiber does genuinely help many people, but not everyone, and not automatically. Fiber generally works by adding bulk and helping stool retain water, which can make it easier to pass, especially when stool has been hard or dry. But if fiber is increased quickly, especially without enough fluid alongside it, it can lead to more bloating, more abdominal discomfort, and in some cases, more difficulty evacuating, not less. This matters most for a group of people whose stool isn't actually hard at all. Their stool may be a reasonably normal consistency, but it still feels stuck at the exit. That distinction is important, and it's one that often gets missed. Stool that is too hard is a different problem from stool that is soft enough but still difficult to push out. Adding more fiber addresses the first problem. It usually does very little for the second, and can occasionally make someone feel worse if the real issue is at the outlet rather than the stool itself. The medications that can quietly change your bowels. Here's something worth reviewing with a doctor or pharmacist, because it's easy to overlook. Several categories of medication can contribute to constipation, sometimes quietly, over months or years. This can include opioid pain medications, certain medications with anticholinergic effects, some allergy medications, some medications for overactive bladder or certain neurological conditions, as well as some iron supplements and some calcium supplements. This is not a complete list, and it isn't meant to alarm you about medications you may genuinely need. I want to be very clear about this. Never stop a prescribed medication because of a video. What's useful instead is bringing a simple, specific question to your doctor or pharmacist. Ask directly whether anything you're currently taking could be contributing to your bowel symptoms. Sometimes, the answer is no. Sometimes it opens up a conversation about alternatives or adjustments that can genuinely help. The hidden pelvic floor problem. Now we get to the part that may connect everything you've been experiencing. For some people, the stool isn't especially hard. They're drinking enough fluids, and they're still struggling to empty completely. The problem can be pelvic floor dysfunction, including something called dysenergic defecation. In simple terms, when you're trying to have a bowel movement, the muscles that should relax and open may stay tight, or even tighten more. It's like pressing the accelerator while the brakes are still on. You create more pressure. You strain harder, but the outlet doesn't cooperate. That can lead to a very recognizable pattern. Stool feeling trapped near the rectum, spending too long on the toilet, making repeated attempts, straining excessively, feeling like you haven't finished, or needing to change position, or use your hands to help. Now, this does not mean you have pelvic floor dysfunction. A video can't diagnose that, and other conditions can cause similar symptoms. But if you've been told to eat more fiber, drink more water, and take stool softeners, and you've done those things, yet still feel like the problem is right at the exit, this is worth specifically mentioning to your doctor, because the treatment can be completely different. The fix that targets the actual problem. When pelvic floor dysfunction is confirmed, one of the main treatments is pelvic floor physical therapy with biofeedback. Here's what makes it different. Instead of simply trying to soften the stool, a therapist helps you learn how to coordinate the muscles involved in evacuation. Sensors can provide real-time feedback, showing whether the pelvic floor is relaxing or tightening while you bear down. You're essentially retraining the push and release pattern your body needs. For the right patient, that can target the actual problem rather than repeatedly treating the symptom. Doctors may also use tests, such as anorectal manometry, which evaluates pressure and muscle coordination, or a balloon expulsion test, which assesses whether you can effectively pass a small balloon. Not everyone needs these tests, and not everyone with constipation has a pelvic floor problem. But knowing these possibilities exists can change the conversation with your doctor, from, "I'm constipated," to something much more useful. "I can feel stool in my rectum, but I repeatedly have difficulty evacuating it and never feel completely empty." That description gives your clinician a much clearer place to start. Let me tell you about Margaret, 68. For almost 3 years, she quietly struggled with a problem she rarely discussed. She would sit on the toilet, feel the stool right there, push, wait, and maybe pass a small amount, but still feel like she wasn't finished. Her friend Linda told her, "You're getting older, it happens." Her daughter Carol encouraged more water, and her doctor recommended more fiber. Margaret tried everything, but nothing really changed. Gradually, it started affecting her life. She turned down breakfast with Linda because she didn't know how long she'd be stuck in the bathroom. She hesitated to visit Carol because she worried about finding a bathroom. Nobody could see what was happening, but Margaret's world was quietly getting smaller. Finally, she told her doctor exactly what she was experiencing. "It's not always hard. I can feel it right there, but it feels stuck at the exit, and I can't finish." That detail changed the conversation. Her clinician evaluated her for possible pelvic floor coordination problems instead of simply recommending more fiber. Treatment took time, but gradually things improved. And the biggest change wasn't just in the bathroom. Margaret started going out again without constantly worrying about where the nearest bathroom was. She felt like she was getting her freedom back. Her story doesn't mean everyone has the same cause, but it teaches an important lesson. Sometimes the symptom you're embarrassed to describe is exactly what your doctor needs to hear. So don't just say, "I'm constipated." Tell them, "It feels like the stool is right at the exit, but I can't get it out." When this is not just constipation. Before we get to a practical plan, I want to spend real time on something important. Knowing when this symptom needs prompt medical attention rather than a wait-and-see approach. Please seek medical evaluation, sooner rather than later, if you notice blood in your stool, black or tarry-looking stool, unexplained weight loss, persistent or severe abdominal pain, vomiting, fever along with significant abdominal symptoms, inability to pass both stool and gas along with significant swelling or pain, a new and persistent change in your usual bowel habits, significant weakness or signs of dehydration, repeated episodes of fecal impaction, or symptoms that are rapidly getting worse rather than staying steady. I want to be careful here, because the goal isn't to make you think ordinary constipation means something dire. Most of the time, This symptom has an explanation that can be identified and managed, but after 60, a persistent or new change in bowel habits deserves proper attention. Because there are several possible causes, and they genuinely shouldn't be guessed at by me, by a video, or by anyone without an actual examination. Your simple action plan. Here's a straightforward way to approach this. First, pay attention to what your stool is actually like. Is it hard and dry? Or is it a fairly normal consistency that still feels difficult to pass? That distinction is one of the most useful things you can bring to a doctor's appointment. Second, review your full medication and supplement list with a doctor or pharmacist, and specifically ask whether anything could be contributing to your symptoms. Third, keep movement and daily activity going as much as is medically appropriate for you. Fourth, maintain sensible hydration, unless a doctor has specifically told you to limit fluids for another medical reason. Fifth, try a more supported toilet position, feet elevated slightly, leaning forward, staying relaxed rather than tense. Sixth, avoid prolonged, forceful straining, even when it's tempting to just push harder. Seventh, if your stool is reasonably soft, but still feels stuck at the outlet, specifically ask your doctor whether pelvic floor dysfunction or a defecatory disorder could be part of what's happening. And eighth, if symptoms are persistent despite reasonable changes, ask what evaluation makes sense for your situation that might include a rectal exam, further medication review, colon evaluation if indicated, or specialized testing like anorectal manometry or balloon expulsion testing, depending on your history and what your clinician finds. If it would help you start that conversation, here's language you can use almost word for word. I've been having difficulty evacuating stool, even when I feel the urge. It often feels like the stool is right at the outlet, and I don't feel completely empty afterward. Could a medication, a pelvic floor problem, or something else be contributing? Having that sentence ready can make an embarrassing topic much easier to bring up. Let's come back to where we started. You feel the stool right there, but it won't come out. If that sentence describes you, I don't want you walking away from this thinking your body is simply failing because you're getting older. Sometimes, the problem isn't that your body forgot how to have a bowel movement. Sometimes, it's the final step, the coordination between pushing and relaxing, right at the exit, that isn't working the way it's supposed to. And once that specific cause is identified, the solution can become far more targeted than eat more fiber and hope. You are not disgusting for having this problem. You are not alone in it. This is far more common than most people ever say out loud. You are not necessarily broken. And you don't have to keep quietly accepting it as simply part of getting older. If this explains something you've been experiencing for a long time, consider sharing it with someone who's mentioned struggling to feel completely empty, or who always says they just can't seem to finish. This is exactly the kind of health topic people rarely bring up until they've dealt with it for years. And if you found this helpful, subscribing and liking helps this reach more people who are quietly dealing with the same thing. If you're comfortable, let me know in the comments. Do you usually deal with hard stool, a sense of incomplete emptying, or that specific feeling of stool being stuck right at the exit? It helps others realize just how common this actually is. Sometimes, the most important health problem isn't the one that hurts the most. It's the one you've gotten so used to that you stopped asking whether it could actually be treated.